Hello everyone, I'm Massimo Calafiore, and I'm so excited to be here in our Surgeon Experience Center in San Diego, the largest surgeon training spine center in the world. And this is just a representation of what NuVasive is. We are a company built on innovation, on comprehensive procedural solution. All of this let us become the largest spine-focused company in the world. And because of you and because of our technology, we were able to touch million patients globally. Today you'll hear from few of us and from our surgeon partner all around the country. Look, our goal is to be the best. We are the best in lateral, we are building the best portfolio in posterior spine, and now we found the opportunity to reimagine cervical. And we are very excited to show you our latest innovation. Take a look. We just saw together our new cervical portfolio, C360. As you can see, has been a huge investment for us. And now, live from Atlanta, Dr. Reg Hayde.
Massimo, thanks so much. It's an honor to be here. On a personal note, I'd just like to make it known a few things about the man on the other side, about Massimo. So for over 30 years, I've designed with different companies, and working with NuVasive at this time and this man and this team has been really novel and a lot of fun. So Massimo's really operationally built the team that allowed all of us surgeons to work with excellent engineers. So Massimo, hats off to you.
Thank you, Reg. And now let me ask you a question. What makes you excited about our new portfolio, C360, and the new plate ACP?
That's a good question. You know, it's been a lot of fun to work on this project. Anterior cervical is kind of novel because we've been doing it for so long. Most of us think we're pretty good at it. Our results are good. But as we sat down with this project with the other surgeons and the other team of the engineers, you know, I'm kind of a sports guy, and it's like, what makes certain coaches great? And it's attention to detail, and it's breaking down the game into segments. And so we broke down the anterior cervical procedure into segments, into approach, into dysphagia, thinness of plate, pseudoarthrosis, unicortical screws, bicortical screws, different types of pathology. We looked at the different types of interbody constructs and their modulus of elasticity, their affinity for bone, whether there's biofilms, whether there's osseous integration. And when we put all of these thoughts together, we actually came to realize that there was a lot of nuance that we missed. And what we missed was the chemistry, the interplay between the plate, the bone, the screw, the interbody spacer. And we've really tried to drill down and to make each part of that procedure optimal. Is it perfect? No. But is it better? Oh my gosh. It's so much better because we're paying attention to detail, and we're going to continue to pay attention to detail and take it to the next level. But first, I'd like to introduce a few of our surgical design team. NuVasive has assembled a phenomenal group of design surgeons. And much like a football team has an offensive team and a defensive team and a special team, we actually broke down into teams to focus on interbodies, anterior, posterior. And so we went to them and asked them, why are you excited about this project? Let's take a look.
What excites me about the C360 system is that they have assembled what I consider to be the dream team of cervical spine surgeons, both neuro and ortho surgeons who are internationally renowned and together have nearly a 200-year combined experience in doing cervical spine procedures. And they brought all of this experience together to design what I consider to be the state-of-the-art system for doing cervical spine procedures.
I'm excited about C360 because I think it's going to change the face of cervical spine surgery.
When we were given a blank slate to go and design products that are going to go and revolutionize cervical spine surgery, the culmination of that effort is embodied in C360. It is a fabulous suite of products.
I'm excited about C360 because it's the first time ever that experienced cervical spine surgeons and very, very innovative engineers have come together to, with a blank slate, create both anterior and posterior cervical solutions for our patients.
It's great that we heard from the broader team and all of you heard their common experience with the system. So now, Reg, please take it away again.
Thanks, Massimo. As you know, we've been working on this diligently, to say the least, the past 2 or 3 years. And a lot has come out of this. We've just completed over 600 alpha and beta cases of our new anterior cervical plating system. After the design team reviewed the game film, as it were, and broke down the procedure into segments, we were very deliberate, and we focused on nuance. And dysphagia issue, pseudarthrosis is an issue, alignment, stiffness, versatility, right? And so it came down, we thought about plate stiffness, plate versatility, and plate thinness, and tried to figure out how to assemble all of those parts together. And it was really combining the plate and the screw and the inner body to figure out that chemistry to how to give the ultimate outcome. So let's dig down a little bit into this. 1.6 ultra thin plate, 1.9 highly versatile plate, 2.1 stiffer plate. So let's go over to the West Coast where Dr. Sasso is, Rick Sasso from Indianapolis, a friend and esteemed colleague for 30 years. Rick, tell us about the 1.6 ultra thin plate.
Thanks, Reg. I'm super excited about our 1.6 millimeter plate. This is the thinnest plate on the market. This is designed to decrease the incidence of dysphagia and still allows hyperangulation of the screw through the plate, to decrease the height of the plate to stay away from the adjacent disc, to decrease the incidence of adjacent level ossification of that disc. We also have a 1.9 millimeter plate, which is still a very, very thin plate, allowing fixed and variable screws through the plate. Also, 2.1 millimeter plate, which is designed mainly for deformity correction, which traditionally has been very difficult to do with traditional anterior cervical plates.
Rick, thanks so much for telling us about the 1.6 ultra thin plate. And for those of you viewing us on YouTube Live, please add to the chat and let us know about the ultra thin plate. You know, when we've discussed this concept of anterior cervical chemistry, we've talked about different plate thicknesses. Next, I'd like to introduce the 1.9 thin, which is highly versatile. So our next speaker is Dr. Todd Albert, we're going to chat with. And Todd, thanks for joining us from the East Coast. And I just can't resist. Live from New York, it's Todd Albert. Tell us about the 1.9 plate and the concepts behind that.
Thanks, Rich. It's my honor to be able to share my thoughts and our team's thoughts about the versatility of the 1.9 plate. What I believe we've achieved, and what we aspired to achieve at least, was versatility with this plate. This plate is the thinnest plate on the market that allows both fixed and variable screws to be put through the same construct. So if you need a fixed, stable environment in a tumor or trauma, you have it in this plate. If you want dynamism, and I'm a huge believer in dynamism in degenerative constructs where we want to assist with fusion, we want loading of our grafts or interbody spacers, you have it with this plate. You have all in one across every level of the spine, 1 to 5 levels, and for any type of pathology. And as Rick just said, the thinness of the plate is important, but also for this, the versatility is important. So you attain that chemistry of the interbody choice along with the plating choice for the overall construct. And as we think about the montage of what we're trying to do for the entire cervical spine, I think this plate, the 1.9, is a super important component of it.
Todd, what's interesting is what you and I have learned on this project, right? We've known each other for decades. And now I think about the versatility of the different plates and the screws and the interfaces, and that combined with the selection of interbodies, right? Whether it's bone or PEEK or porous PEEK or 3D printed titanium, that allows the surgeon to really customize the implant for the pathology, the deformity, the bone quality, et cetera.
I totally agree with you, Reg. You know, everybody likes to talk about personalized medicine. This is personalized cervical spine surgery. And this plate allows you to personalize the construct for the specific patient and the specific surgeon.
We used to say a plate's a plate's a plate. I think we were wrong. I think we've learned a lot. Todd, thanks so much for joining us today. Todd talked about hybrid and fixed and variable screws, but what about screw lengths, diameters, self-drilling, self-tapping? And I think this is a great time to switch it to our engineers. They're in San Diego. We have a phenomenal group of engineers who have just knocked it just out of the park with this. Guys?
The biggest challenge when tackling this project was, how do we design a plate that can stand out? To do this, we interviewed our design surgeons and found that there were complex multifactorial problems such as dysphagia and plate stiffness that we could address. We then went and looked at our competition and found that the competition had made sacrifices with respect to plate versatility or construct versatility and plate profile. After seeing all of that, we knew that there was an opportunity for us. We just needed to design the plate.
So one of the main goals of this project was to have the thinnest plate on the market. And as we started to dig deeper with our design team in terms of, number one, could we have the thinnest plate on the market? And number two, should we have the thinnest plate on the market? We began to realize that there was likely not a single plate profile that was going to meet the needs for the entire spectrum of anterior cervical constructs. And so from there, we ultimately decided to offer surgeons the ability to pick and choose the correct construct for their unique patient needs. And what that meant was we ended up offering 3 unique plate thicknesses, a 1.6, a 1.9, and a 2.1 millimeters, as well as a fixed and a variable screw option. And from there, we allowed the surgeon to really fine-tune what they were going to do for each individual patient requirement. From a strategic perspective on this project, we started off with optimizing the 1.6 millimeter plate first. And in order to do that, we stripped it of all the features that weren't essential. So we omitted the fixed screw off option in the 1.6 millimeter plate. And from there, when we decided to add the 1.9 and 2.1 millimeter plates to the system, we knew there was an opportunity to reintroduce the fixed screw option into those thicker plate profiles. One of the clinical needs that we really wanted to address from a design perspective for the ACP project was trying to reduce a patient's risk for developing dysphagia. And so the plate profile, plate thickness obviously plays a role in that. But in addition, we were hyper-focused on the anterior surface of the plate in order to maintain a smooth, continuous surface that would limit soft tissue irritation.
To get the thinnest plate profile possible, we started by isolating each component individually, such as the waist, the lock position, and the graft window. By isolating each component, we were able to optimize them by running simulations on it. The goal was to get a smooth, continuous surface that would evenly distribute the loads and reduce the stress concentrations that lead to failure.
So there you have it. We had a chance to review what the engineers did. It's not just what the engineers think or the design surgeons think, it's what you, the practicing surgeons, think. So we had our alpha and beta surgeons, and I had a chance to speak with one, Dr. Amy Wickman in Santa Barbara, and catch her thoughts via Zoom. Did the engineers accomplish what they wanted to accomplish? Let's take a look.
You're really a knowledgeable surgeon. So just give us some insight, since you were an alpha tester, about what you think about the 1.6 and the 1.9 plates.
I am always a little skeptical when I'm trying new instrumentation. I think like any spine surgeon, we sometimes get a lot of new stuff thrown at us. And I was beyond pleasantly surprised. I was pretty thrilled with the ACP when I first tried it out from the get-go on the very first case. You could tell right away that it was an ultra thin plate. It was super smooth. The ease of use, even from the first case, was obvious. You know, sometimes with new instrumentation, you really have to have a little bit of a learning curve, and this was really pretty straightforward and easy to use. I really appreciated the locking mechanism. It was much more smooth. It completely covered the screws easily, and there wasn't any difficulty getting it to cover the screws, even depending on the depth that you could get those screws down. That was definitely nice. And then even the handling of it, you know, for those of us who are doing, you know, smaller incisions, more minimally invasive 1 and 2 levels, the instrumentation itself was very minimally designed to fit under the microscope in small incisions. And that was really appreciated, for sure. So I'm really happy with the plate. I would highly endorse it to my colleagues. Like all surgeons, when your patients come back from a surgery that you think's a home run and they notice a little swallow difficulty or speech difficulty, you get frustrated. And with these really thin plates, I mean, you know from the Lee paper that that's not going to be as much a problem. It's going to make a big difference. And certainly, you know, even in the first early trials, we see that happening, I think, with this plate, because it's so thin and so light, and but while still maintaining the biomechanical strength. Sometimes you worry that, oh my gosh, this, you know, some of those old plates that didn't have 4 screws, but just 2 screws, which I don't think I ever put in anyone because it made me nervous. But the biomechanical properties of this plate are still outstanding. So you feel comfortable putting a strong plate on, but you don't have to worry about the dysphagia.
Amy, thank you so much. It's an honor and a pleasure to speak with you.
Thank you, Reg. You too.
Well, we've had some opportunity to listen to Rick and Todd bi-coastal about the 1.6 and 1.9. I have the honor of actually in person Chris Shaffrey, my good friend and renowned colleague. We've asked Chris to sit and talk to us a little bit about longer segment, stiffer plates and lordosis.
So one of my interests is in spine deformity. And one of the areas where I think there is increasing data that achieving good alignment in the spine is very, very important. And one of the design aims was to go and find correct solutions to be able to achieve some of the challenges. One of the challenges I've had was that in the past, I used to try to go and use a plate to pull the spine up to it for anterior correction. And what I would find frequently was the plate would bend out. Instead of the spine being pulled up to the plate would bend down to the spine. Is that something that you've experienced?
Yeah, in fact, it's funny. I assumed I was bending the spine and I was bending out the plate, even thicker plates.
Well, and what happened is I've learned over the last several years that so much of the correction really is done through the inner space.
Yep.
And not forcing the spine up to the plate.
Hyperlordosis, hyperlordotic implants, right?
And so, yes, exactly. And so what I've moved is, particularly for people with good bone quality, is to use the modulus titanium lordotic implants. And by working segmentally down the spine, opening each inner space, loosening the spine, and then putting in a lordotic implant, the force that the plate needs to exert on the spine becomes relatively minor, and it's more holding the spine in the level of correction. So what had happened, a previous mistake that I had made, was recommending thicker plates so that they wouldn't bend out to allow the spine to move up to the plate. And what I found when I operated on those patients, I was having more dysphagia, particularly when you had an extensive surgery where you do something like C3 to C7, then suddenly a lot of these people had swallowing problems. So what I had learned, and I think there's increasing literature on this, is that the thicker the plate is, which has advantages in correction, also has a greater risk of dysphagia. Another area was that a number of plates that I have used have a lot of surface irregularity, such as the locking mechanism.
Yes.
And these proud locking mechanisms have a tendency to also, I think, induce dysphagia. And there's at least one really strong paper that goes and shows that plate thickness and surface irregularity of the plate is really a factor in dysphagia. So with the 2-1 plate, we wanted to make a plate that was biomechanically strong enough to hold a deformity correction, but to make it thin enough to hopefully reduce dysphagia and to really focus on an exceptionally smooth surface. And it's my belief and the belief of the rest of the design team that by adding those different factors together, that we have the biomechanic strength, we have the stiffness that we need, we have the surface smoothness, and added together, I really do think that we're having an ideal implant to allow us to achieve the goals of deformity correction in the cervical spine.
You know, I think you've hit the nail on the head. I think as we looked in greater depth at the nuance of this procedure, we've all kind of arrived at the same position, and we're focusing on contour, stiffness, but the inner bodies. You and I both know Trey Crawford at Leatherman in Louisville, orthopedic surgeon, and had a chance to talk with him via Zoom a couple weeks ago just about the different types of inner bodies and the materials and the lordosis and how he selects them. So if we can just go to that Zoom real quick with Trey and see what he thinks.
When do you use allograft or PEEK or porous PEEK or 3D printed titanium?
Just keep progressing with this 3D printed titanium and the porous PEEK as well. Essentially using that exclusively. But I just had too many patients, too high of a percentage for me who would not maintain their disc height. And an ACDF is just such a great procedure. It wasn't acceptable to me to have that 10% or 15% non-union rate. Honestly, in my practice right now, it's mostly 3D printed titanium, but the porous PEEK cases that I've done, I've been extremely happy with as well.
Does number of levels matter to you in how you select things?
Certainly, looking at the multi-level constructs, I think, historically in the literature and also my personal experience, it's a higher non-union rate. I think some people think about it, it's a 10% chance at each level. So the more levels you do, the higher the chance that you're going to have a non-union. So I really like the lordotic options that are available with the interbody devices, and absolutely think that the fusion rate is a problem using a multi-level allograft. So I really like the 3D printed titanium for a multi-level construct.
I'm doing many more A-lifts for lumbar disease than I ever did. And I'm, just as you said, I'm translating that anterior lumbar experience to the anterior cervical experience. So tell me how you select lordosis. I'm becoming more and more hyperlordotic, as it were. And I think a lot of our restoration of alignment is not via just the plate, it's via the inner body and the hyperlordotic inner bodies. What's your thoughts?
I think the same thing. I do a lot of anterior lumbar interbody fusions, especially at L5S1, trying to restore disc height, restore lordosis. And I think of that in an ACDF in a very similar way. I think if you looked at my interbody usage over the last several years, I think the most common lordotic implant that I use is a 10 degree.
I agree. One of the things I'm excited about is this term that I was talking with Todd Albert about, this anterior cervical chemistry, what we're figuring out between plate rigidity, plate screw interface, the modulus of the implant, be it 3D printed titanium or porous peak. I think we're really starting to learn a lot more about how to optimize.
Absolutely. There's no question that an ACDF has for a long time been one of the better procedures that we can provide to patients. But still, you know, I look across the operating theater sometimes and I'll see the hip surgeon over there, and I know he's getting, you know, 99% good outcomes in his patients. And I want 99%, you know, or even, you know, just stretching for that 100% great outcomes in my ACDF patients. So
I just want to thank you for taking the time today to chat with us. Just want you to have a great day.
You too, Reg. I miss seeing you and all of our colleagues in person. I know we're all looking forward to the day we can all be back in the same conference room together.
Cheers.
Cheers.
We've talked about a lot of concepts this evening, some of them new. We've talked about anterior cervical chemistry, or the interplay with the plate and the screw and the spacer. This team is really excited to bring this to you, and we really want you to dig in and let us know your thoughts. We think you'll find this to be an exceptional way to take care of your patients. And before we sign off, I'd like to take you back to San Diego. We're going to show you a sneak peek of something really cool I think that you will enjoy. So signing off from Atlanta, I'd like to tell you that you're always welcome to reach out to us. So please reach out, and I wish you peace and safety.
Thank you, Reg. And I'm here now with Dr. Rick Sasso from our Experience Center in San Diego. First of all, thank you for coming. And I hope you're enjoying the visit here with us. Give us your thoughts about the day.
It's been a great day. And I think everyone has seen the hard work that has come to fruition now. The last couple of years, we've been working really hard to put together an anterior cervical system that makes sense and can help us with all of our various pathologies that we see in our patients. And we've been able to assemble some of the most innovative cervical spine surgeons in the world and match them up with some incredible engineers. And the problem is that in the past, there have been, we release an anterior cervical plate, and that is supposed to be the one system that fits all pathologies. And we know that that's not the case. Not every size fits all. And so what we've been able to do with a blank slate is come up with a system, a portfolio that allows us to target the very specific pathology that our patients have and design a solution for that. And it's been fabulous to see that all come together now after a couple of years of really hard work.
Well, we're very glad, and it's great from hearing this from you that, you know, I've been in this industry for so many years. Thinking about our effort and our investment in cervical, ACP is just the first step of the creation of this C360 platform that encompasses also posterior cervical system. We will call it Reline Cervical. Now that, you know, having you here and knowing that you already had a little sneak peek of the system, what do you think?
Well, it's fantastic. And again, when you put together some of the most innovative cervical spine surgeons in the world and match them with some incredible engineers, been able to come up with an amazing posterior occipital cervical thoracic system. And in the past, we haven't really focused in on some of the most difficult parts of a posterior cervical system, and that's the junctions, occipital cervical and cervical thoracic junctions. And I think that you're going to see that this is an incredible system that allows us to, the best we can, manage the junctional aspects of the cervical spine.
That's great to hear. You know, like Reline Cervical, it just it follows the philosophy that we have around Reline. The versatility of the system is going to, as you described, is going to be an important factor to differentiate. But beyond that, we will be the first company that will launch a specific fixation system with enabling technology. And you know, we will be very glad to see Reline Cervical alive with our Pulse platform. So, we heard from you. Now it would be great to hear, the opinion of one of your colleagues.
I think the Reline C is going to make the surgeon's life a lot easier. And the frustrating part of the case when you're trying to engage the rods to the screws, that's when you're going to see that there's a big difference with the Reline C system.
Thank you for being here with us tonight. I'm sure that you are excited as us about our new offering in cervical. C360 is a portfolio that is going to change how you think about cervical. And this is another opportunity for us as a company and for you to even change more patient life. And we really hope to see the proliferation of this platform all around the globe. And have a good night.